Usually when we talk about a medical diagnosis, there's this expectation of total precision. Like it feels almost like engineering, right?
Right. Yeah, very mechanical.
Exactly. Like you break your arm, the X-ray shows that jagged white line, and the doctor just points at it and says, there it is, it's broken.
It's binary. I mean, it's either broken or not broken. It's clean. And honestly, in medicine, we like things to be highly visible and easily categorized because, well, it makes the treatment path really obvious. You put a cast on it and you let it heal.
Right, but then you step into the world of modern oncology, specifically urologic cancers, and suddenly that X-ray machine feels just completely inadequate.
Oh, totally. It's not even close to enough.
Yeah, we are looking at this diagnostic and therapeutic landscape that is just incredibly complex. It's less like fixing a broken bone and a lot more like playing three-dimensional chess, but the board is actively changing shape while you're playing.
That's a really good way to put it.
And to understand how clinicians are actually playing this game today, we're diving into the definitive playbook. So our source material today is the 2022 textbook, Urologic Oncology, Multidisciplinary Care for Patients, edited by Kelly L. Stratton and Alicia K. Morgans.
And this text really captures a pivotal moment in the field. I mean, we are aggressively moving away from those old anatomical organ-by-organ treatments and moving toward a deeply biological systemic approach.
Which is wild because the science is evolving so fast.
Faster than standard clinical workflows can even keep up with in a lot of places, yeah.
So for you listening, whether you're a medical student prepping for boards, a young professional trying to refine your clinical acumen, or just someone who is insanely curious about the frontiers of medicine, we designed this deep dive as a high-yield clinical primer just for you.
Because, understanding the biology of a tumor is really only half the battle. If the hospital system itself isn't structured to act on that biology effectively, I mean, the patient still loses.
Right, which is the perfect roadmap for today. We're going to start with the structural paradigm of how care is delivered, then move into surgical optimization for kidney cancer, explore the widely divergent tumor biologies of bladder and upper tract cancers, and then look at the shifting sands in advanced prostate cancer.
And then finally tying it all together with the really critical umbrella of palliative care.
Exactly. Okay, let's unpack this. Because this massive structural shift in how cancer care is delivered is so crucial, I like to think of the traditional medical system as a relay race,
Yeah, handing off the baton.
Right. A patient sees a urologist for the diagnosis. Then maybe weeks later, the urologist passes the baton to a medical oncologist to talk about chemo. Then maybe another handoff to a radiation oncologist. And you just kind of hold your breath and hope nothing gets dropped in those transitions.
Which it often does. I mean, modern genitourinary care is just far too complex for that siloed approach. The gold standard has really shifted to a pit crew model.
The multidisciplinary clinic.
Exactly. The MDC, this is where all these specialists swarm the patient's case at the exact same time, in real time, rather than doing sequential appointments.
But practically, how does a hospital actually pull this off without it becoming a logistical nightmare? Getting all those doctors in one room sounds impossible.
It is incredibly difficult to orchestrate, honestly. But we look at historical blueprints like the Sidney Kimmel Cancer Center model. They established this back in 1996.
Wow, 1996.
Yeah, Dr. Leonard Gramella and Dr. Richard Valicenti pioneered it. And while prostate cancer makes up about 80% of their patients, the model applies to all GU cancers. And the data just proves why this structural shift is mandatory.
Like what kind of data?
Well, take muscle-invasive bladder cancer. The gold standard is giving the patient neoadjuvant chemotherapy, so chemo before surgery. In a traditional fragmented system, historical rates of patients actually getting that chemo hovered around like 20 to 40%. It just fell through the cracks.
It's devastating.
Right. But at a dedicated multidisciplinary clinic like the Kimmel Center, 70% of their muscle-invasive bladder cancer patients receive that standard of care treatment.
70%. That is a massive difference in survival outcomes simply based on how the doctors communicate with each other.
Exactly. And the blueprint for how they do it is really specific. Before the patient even walks in the door, there is a preclinic multidisciplinary tumor board, or MDTB.
Okay, so that's where they review the pathology and the imaging.
Yeah, you have the dedicated specialist reviewing everything, debating the medical, surgical, and radiation perspectives, and synthesizing a master plan. But the real unsung hero making all of this happen is the dedicated nurse coordinator.
Oh, the linchpin.
Absolute linchpin. They manage the scheduling, they navigate the patient, they pull outside records, and an added bonus of this whole structure is for the trainees.
Right, the residents and fellows.
Yeah, being present in that room is an incredible educational exposure. They don't just learn surgery, they learn how a medical oncologist actually thinks.
That's huge.
Yeah.
So this multidisciplinary pit crew comes up with a master plan. But, once they decide a surgical route is necessary, the biggest hurdle becomes making sure the patient's body can actually survive the operation.
Mhm.
Which brings us to kidney cancer, right?
Yeah, renal cell carcinoma, or RCC. The stakes for surgical intervention here are just incredibly high. The survival disparities are stark. For localized disease, the 5-year survival rate is actually fantastic. It's around 93%.
But if it spreads,
If it's distant metastatic disease, that survival rate plummets to 12%. So surgery is the absolute mainstay of treatment, but it's risky.
yeah, the inpatient complication rates are kind of eye-opening. We're talking about a 19% complication rate for just a standard non-metastatic nephrectomy.
And if they have to perform a cytoreductive nephrectomy, meaning they're taking out the primary tumor in a patient who already has metastatic spread to reduce the cancer burden, that complication rate jumps to 27%.
With a 2.4% mortality rate right there on the table. So, predicting who is actually going to recover from that kind of trauma, you have to look past a patient's chronological age, don't you?
Absolutely. You have to measure physiologic reserve because predicting surgical complications requires looking at how the body responds to stress, what we call frailty, not just the date on their birth certificate.
So age is just the mileage on the odometer, but frailty is the actual condition of the engine and transmission.
I love that analogy. Yes. A healthy 75-year-old can have a much better engine than a 60-year-old with poorly managed diabetes. The challenge is, how do you measure that engine condition objectively in a really busy clinical workflow?
Right, without spending 2 hours doing a geriatric assessment on every single person.
Exactly. So clinicians use validated tools. There's the 11 CSHA, which is the Modified Frailty Index, but an even more practical one is the Overall scale.
This is just 5 items, right?
Yeah, a 5-item assessment easily pulled from medical records. It measures fatigue, resistance, ambulation, illnesses, and loss of weight.
That's brilliant. It's this rapid way to see if they need aggressive optimization before hitting the OR. But while optimizing physiology is crucial for kidney cancer, predicting outcomes in bladder cancer requires looking deeply at the biology of the tumors themselves.
The urothelial spectrum is where things get really fascinating.
Yeah, let's break down the pathology. Non-muscle invasive bladder cancer, or NMIBC, accounts for about 70 to 80% of cases, right?
Right, and that includes your TAN tumors, T1 tumors, and carcinoma in situ, or CIS. But the most critical concept here is divergent tumorigenesis.
Okay, unpack that for us.
So low-grade and high-grade NMIBC follow entirely different genetic pathways. Low-grade tumors typically involve a loss of chromosome 9 or mutations in the FGFR3 and RAS pathways.
And high-grade.
High-grade tumors, including CIS and T1, are driven by chromosomal aneuploidy, so problems with chromosomes 7, 9, 17, and mutations in major tumor suppressor genes like PRB, P53, or P21.
Wait, really? So we shouldn't think of high-grade bladder cancer as just like a low-grade tumor that grew up and got worse?
Not at all.
They're actually more like 2 completely different species of weeds in a garden.
Yes, that is exactly it. It is a fundamental biological difference from their very inception.
So a low-grade weed is easy to pluck, but that high-grade weed has a completely mutated toxic root system from day one.
And if that aggressive root system invades the muscularis propria, it becomes muscle-invasive bladder cancer, or MIBC. And at that point, you have to treat it as a systemic disease right away because of occult micrometastases.
Meaning little invisible seeds of cancer have already escaped into the bloodstream.
Right. If you do surgery alone, like a radical cystectomy, you're looking at up to a 50% distant recurrence rate. The primary tumor is gone, but the seeds were already planted.
Which is why neoadjuvant or adjuvant systemic therapies are just so critical. But, removing the entire bladder is a huge deal.
Yeah.
So for bladder-sparing and SBP-selective bladder preservation, the text talks about trimodality therapy.
Yeah, TMT. This is that multidisciplinary pit crew shining again. It's a 3-step approach. First, a maximal safe 2-RBT by the urologist to physically debulk the tumor.
Is clearing the field.
Exactly. Then concurrent chemotherapy drugs like cisplatin, 5-FU, and mitomycin C or gemcitabine.
But the chemo is working as a radiosensitizer here, right?
Yeah.
Making the cancer vulnerable for the 3rd step, which is the radiation.
Exactly. And the radiation oncologist can use either standard dosing, like 64.8 Jg in 36 fractions, or a hypofractionated approach.
Which is faster.
Yeah, 55 jg in just 20 fractions. It's incredibly effective for patients who need to keep their bladder, but for metastatic bladder cancer, where it's spread, the median overall survival used to be around 3 months.
3 months, that's bleak.
It was, but modern trials are showing median survival around 15 months now, and that's because we've combined platinum-based chemotherapies with immune checkpoint inhibitors, specifically PD-1 and PD-L1 blockade.
That's the fake ID mechanism, right? Where the tumor expresses PD-L1 to trick the immune system, and these inhibitors just rip the fake ID away.
That's exactly how it works. And just briefly, since we're on urothelial cancers, we should mention upper tract urothelial carcinoma, or UTUC.
Right, because the urothelium goes up into the kidneys, too.
Yeah, it makes up about 10% of urothelial cancers. It's twice as common in the renal pelvis as it is in the ureter. It typically affects older patients, around 70 years old. And a key point is that variant histologies, like squamous differentiation, carry a significantly worse prognosis.
So while localized and metastatic bladder cancers require these multimodal assaults, prostate cancer management is currently experiencing this technological renaissance in how we even find the disease.
Oh, the imaging advancements are completely changing the game.
Let's talk about high-risk localized disease.
Yeah.
Because 1/5 of localized prostate cancer cases are high risk.
Right.
And while they're curable, they carry a huge risk for occult metastasis.
Right, and standard CT and bone scans were basically blind to microscopic disease. I mean, a CT needs a lymph node to be about 1 centimeter large before it even flags it.
So doctors just had to rely on statistical nomograms to predict relapse, right? Just guessing based on math.
Exactly. But now we have molecular imaging, like the PSMA PET scan. It targets a specific protein on prostate cancer cells and lights them up no matter how small they are.
And seeing that hidden disease has caused this massive evolution in radiation paradigms. Because historically, radiation for metastatic prostate cancer was purely palliative.
Yeah, it was just to start pain, stop bleeding, or prevent cord compression.
But now, with highly effective systemic therapies like docetaxel and newer antiandrogens, there's an actual algorithm for curative or ablative radiation. And here's where it gets really interesting.
The synergy.
Yes, the better systemic drugs don't make local radiation obsolete. They actually make local radiation more valuable because the drugs hold back the microscopic spread while the radiation just obliterates the main targets.
It's an incredible 1-2 punch. For metastatic hormone-sensitive prostate cancer, if a patient has a low metastatic burden, the algorithm shifts. If it's de novo disease, meaning they just presented with it, we use primary tumor-directed curative radiotherapy.
And if it's oligo-recurrent disease, like it came back in just a few spots,
then we use metastasis-directed ablative radiotherapy to just knock out those specific spots.
But of course, these systemic drugs have a cost. We've got to talk about bone health.
It's a huge issue. About 3 to 8% of men in North America and Europe present with metastatic disease, which often goes to the bone.
And the treatment itself causes problems, right? Androgen deprivation therapy, or ADT.
Right. ADT starves the cancer of testosterone, but it also causes severe treatment-related bone loss. So managing bone health is an absolutely critical part of the care plan to prevent fractures.
Which naturally bridges us to the most vital, yet often overlooked, aspect of oncological care, treating the patient's lived experience. Segment 5, supportive and palliative care.
And we have to define this properly. Palliative care is not just end-of-life hospice. It is specialized multidisciplinary care focused on the relief of suffering.
And comprehensive pain management is at the top of that list. You can't just throw pills at a patient. The text breaks down neural pain mechanisms into 2 distinct categories, doesn't it?
Yes, medical professionals must distinguish between nociceptive pain and neuropathic pain. Nociceptive is from direct tissue injury.
Like a bone metastasis.
Exactly. That's somatic pain easily identified, aching, throbbing. Or it can be visceral pain, which is diffuse and cramping, like from the liver capsule stretching.
Okay, and neuropathic pain.
That is indirectly related to tissue injury. It's actual nerve damage.
But if a patient has advanced cancer, aren't they usually experiencing a messy combination of both? Like, how does a clinician parse that out in a standard 15-minute visit?
It takes a highly detailed pain history. You have to ask about the exact location, the character of the pain, the temporal pattern, and specific triggers. It's the only way to treat it correctly.
Beyond pain, there are chronic lower urinary tract symptoms. Voiding dysfunction is so common. either from the disease or the treatments.
Right. For benign prostatic hyperplasia components or radiation-induced urethritis, first line is usually alpha-1 adrenal receptor agents like tamsulosin and 5-alpha reductase inhibitors.
But if they suspect a malignant bladder outlet obstruction,
Then palliative radiotherapy is highly effective at shrinking that blockage and restoring flow.
which is just life-changing for their daily dignity. All right, to fulfill our educational mission for you, the listener, we've got a quick clinical vignette for you to solve based on today's deep dive.
Let's hear it.
You have a 72-year-old patient with non-muscle invasive bladder cancer. Their pathology report shows chromosomal aneuploidy and p53 mutations. Based on what we discussed, is this likely a low-grade or high-grade tumor, and what are the clinical implications?
Well, the p53 mutations in aneuploidy give it away. That is a high-grade tumor.
Right, the toxic weed with deep roots.
Exactly. It has a distinct biological pathway from low grade. It carries a much higher risk for progression, which means it requires very close surveillance or aggressive localized therapy immediately.
Perfect. So we've gone from the systemic approach of NDCs to the cellular biology of urothelial cancers to the targeted radiation of prostate cancer and vital symptom management. So what does this all mean?
Well, it leaves us with a really provocative thought to ponder. As our targeted therapies and systemic immunotherapies continue to improve overall survival for metastatic patients, we are essentially turning terminal urologic cancers into chronic diseases.
Wow. Yeah, they're living for decades.
Exactly, decades rather than months, which means the side effects like bone loss from ADT or chronic urinary dysfunction are going to be lived with for a very long time. Are our current medical training models adequately preparing future urologists to manage decades-long survivorship? Or are we still too focused purely on the acute surgical strike?
That is a phenomenal question and definitely something for the field to reckon with as we move forward. Thank you for walking us through this incredible landscape. And for you listening, keep learning, stay curious, and thank you for joining us on this deep dive.